Over the past 6 months, MAP Public Policy has interviewed dozens of people living with HIV, as well as artists, activists, advocates, parents, social workers, pharmacists, doctors, and even MAP employees, to see how they felt about the budget cuts, how those budget cuts were affecting people in the HIV community, and what they thought of the idea of health care for all. In the first part of this video, we'll be looking at how the new cost-sharing procedures came about. Cost sharing means anyone living with HIV who's already receiving assistance have to pay an additional percentage of their income, something like a premium, in addition to whatever else they're already paying.
Well, it's our understanding that the Department of Human Services knew that there would be a financial crisis with the AIDS Drug Assistance Program and the Insurance Continuation Program, the programs they call Program HH. And they knew this for some time, months in fact, before it became public knowledge. And apparently they were scrambling internally to figure out what would be their best solution, doing some research into how other states have handled similar crises.
Copies of emails obtained from the Minnesota Department of Human Services to other states reveal the department did indeed make inquiries to states that had implemented cost sharing. And what did they find out? From Washington State,
I have to say, this increase has caused an uproar with clients and pharmacies. I have received letters from 2 clients stating they will have to stop taking their medication because they can't afford the $20 per month on top of all the other expenses.
And from Oregon,
we strongly caution against implementing cost sharing if possible. All of the billing for the premiums and the drug copays are going through the office. It is a huge administrative burden for the loss of clients and the minimal savings. It takes a ton of staff time and has been difficult to enforce equally, in several cases losing the folks who most need the assistance to access care.
But DHS chose to go ahead with the cost shares. At the time of completion of this video, that means over 200 of the people at 100 to 300% of poverty have been unable to make at least one of their cost shares for the last 6 months, and 50 people have been unable to make even one payment. After 6 months, DHS can throw people off the plan. Currently, DHS has no written plan to address the needs of these people.
The way that the cost share was implemented was unfortunately implemented in a very short time frame. So clients were notified about this, in some cases, fairly dramatic change. People went from paying nothing out of pocket to maybe paying up to $150 a month out of pocket to be on the HIV programs. And they were notified about that change 4 to 6 weeks before their first payment was due. So really a short time frame, I think, for coming up with that money.
Well, I think the first thing I'd like to see happen is I'd like a acknowledgement that this is healthcare rationing. Some of the poorest and most vulnerable Minnesotans, yet again, are taking the entire burden or taking a disproportionate amount of the burden on their backs for the financial problems in the state.
Bill Johnson used to work 2 jobs, which brought in $2,000 a month. But that was before his full-time employer stopped offering insurance.
My meds each month cost in the range, I take 3 different meds in my cocktail. I believe the out-of-pocket cost is between $2,500 and $2,700 a month. So you figure that one out.
DHS put him on ADAP, the AIDS Drug Assistance Plan, and told him to quit one of his jobs.
Even though my income didn't change, even though nothing had changed, all of a sudden I had to cut approximately $400 out of my income. On top of that, in order for me to maintain at least some sort of position within their insurance program, within helping me out with my insurance premiums, which are $235 a month, I had to also do cost sharing of $162 a month. So you start adding this up and you're up to about $750, almost $800 a month.
The cuts have affected me pretty much so, because the first of the year I found myself without any insurance, medical insurance. And the stress of that put me into wasting, because we know we don't have the medication to come to us, then we worry. And now, as of August the 30th, I'll be without health care again because there's a cut. I don't know what to do. I've worked all my life.
I just think that's totally unfair for people that are on fixed incomes, that are on disability and have Medicare. And considering I have to have the insurance policy, I can't go without it. I have to pay it. If I don't pay the $85, after 60 days they'll drop me. And without that insurance policy, I have no drugs.
How much is too much for these drug companies to make on these? I know they have to do research work, but most of the research work is coming from the government-supported institutions. My cost on this one is about $600 a month, and they will have to do that. And this one is $360, and this one is $270. So right there, the cost of those is over $1,000.
If people living with HIV can't access or afford their medication, what happens? Amanda Tatra works for a pharmacy that tries to absorb the copays for their customers who can't afford them. Some people have been off their medications for 3 weeks or more, which can result in the development of drug-resistant HIV strains.
If we don't stop them strategically and plan around what types of meds we're stopping, we can see resistance develop. And resistance means that they would have fewer choices when things are working again and they're able to restart meds. Some of those meds would no longer be choices for them and would no longer work against their virus. That's very scary because that means fewer options, less potential time that we can control their virus and that we can give them a healthy life. No one should have to have that as an outcome for financial reasons.
Dr. Alan Lifson is a professor of medicine and infectious diseases and epidemiology at the University of Minnesota's School of Public Health. He's also concerned, not just for individuals, but for society at large.
And one of the things that we know from a number of scientific studies that have been done is that even if you miss 1 dose out of 20, if your adherence is less than 95%, even with that small amount of missing dosages, the chance of failure of the regimen starts to go up. So it really is enormously important that people take their medicines all of the time. One of the things we know from many infectious diseases, and this appears to be the case with HIV itself, is that not only can you have a resistant organism which is within the individual themselves, but that resistant organism can be spread to other people.
My meds, I had a prescription for one of my bottles, and it was a 30-day supply, and it came to $1,300. So if they should cut out disability and Medicaid, my choices would either become homeless or just die. I mean, because I couldn't afford $1,300 a month. I don't pay half that in rent.
For all the problems with the HH program, it's important to remember that the major sources of services for people living with HIV are programs like Medicaid, GAMC, and MinCare.
The most obvious examples of the impact of no new taxes governance on healthcare access in Minnesota, particularly for low-income Minnesotans, and those low-income Minnesotans living with HIV, is that a number of these people received their health care not because they had HIV, but because they didn't have any money. The HIV Insurance Assistance Program and Drug Assistance Program was never designed to provide ongoing access to health care over an extended period of time. So when the state started to step back from its commitment to providing ongoing access to health care through various programs, and people with HIV had to turn to this program that was only set up to provide short-term assistance, that program crashed.
There are many other so-called peripheral services that support people living with HIV that are also being cut, like the food shelf and other food services at the Aliveness Project.
But I know of talking to people here, they do really rely on the food shelf as a means of a support for the basics food that they can pick up once every month, get 2 bags every month or so.
So it's only 2 bags a month, that's what you're allowed?
2 bags a month.
2 bags a month.
Our numbers are increasing every single day. The number of people we serve every day keeps going up, and our budget doesn't. So it's getting tighter and tighter for us. We're actually having to cut out some of the regular services that we've had in the meal program, cut back on the amount of fresh fruit we can get, the amount of salad bar, so it's all like the really nutritional things that you want people to eat that we're slowly having to start to cut back on. Yes, I have heard several people tell me and other staff that if this place were here, there's periods of their life where they wouldn't have eaten. There's several homeless people who come here, to both hang out and to get their food. The holiday weekends that were closed, people are very grateful when we're open again because it's a struggle.
Some individuals adapt to cost sharing by eliminating other expenses.
In fact, the payment that I have that's due for August, I haven't had the money to send it in until today will be my first day of being able to send it in because I had no money to do it. And so I'm already late with that. When you're living on the fixed income of Social Security disability, you just don't have any spare money. One of the things I had to do recently is give up my car.
Folks aren't taking public transportation either because the public transportation doesn't meet their needs, i.e. they may have to take 3 buses, they may have to travel for 2 or more hours to get to their medical doctors or to see their case managers. Sometimes the buses just aren't comfortable. For a person who has, HIV, you may also have neuropathy, you may have other disabilities, which makes sitting on a bus for 2 hours, standing at bus stations, waiting outside in the cold, incredibly uncomfortable, and it may be so uncomfortable that you opt not to see your medical doctor. I have clients right now who aren't going to dialysis because they don't have a ride back home. I can get them there, I can't get them home, they're opting not to go.
Underfunding also affects HIV prevention efforts, particularly for African-born Minnesotans, who comprise less than 1% of the population, yet account for 21% of all new HIV cases. While the Minnesota Department of Health is able to finance some small groups, the money can only fund intermittent efforts at prevention education through groups like the Minnesota African Women's Association.
So our first thing we did was to focus on creating some culturally appropriate educational material for Africans because of the fact that even the way we communicate and speak about disease is completely different from the Western way. But that is completely impossible with budget cuts, especially for nonprofit organizations that end up having just the 1 staff person or the 2 staff people. You need to be able to pay a few willing, even the volunteers get tired after some time. So you need to have people you can pay to really study, learn prevention and everything they can about HIV/AIDS, do the educator training, and go out there and train people.
Language difficulties also mean some Africans can't participate in existing HIV prevention programs.
And we created a program actually consisting of Somali healthcare professionals who speak their language, and also speaking of English. So they are bilingual staff. So this is budget cut always handicap, those kind of projects that are useful for the community.
How do we protect the needs of low-income people living with HIV? Dr. David Holtgrave, head of AIDS research at Emory University, co-wrote a report for the Institute of Medicine commissioned by Congress. The report asserts full treatment for persons living with HIV is cost-effective, Minnesota AIDS Project is working on state legislation that reflects the recommendations.
We estimated that for the program that we proposed, there would be about over a 10-year period, about 20,000 lives that would be saved. Another way to say that is over 10 years we would save 20,000 lives by this program. If we didn't do it, that would mean an additional funeral every 4 hours on average in the U.S.
It's not just people living with HIV, but I want to start the fight there because I feel that people living with HIV are some of our most vulnerable citizens, and so we need to start there. Financially, emotionally, the stigma of their disease, it just is really a place that we need to start.
I think we need different systems in place. I think the AIDS Drug Assistance Program, frankly, is just a Band-Aid, and it's a broken one at that. Immediately, we need some additional funding so that these folks that can't afford the cost shares and the co-pays, or frankly that those things don't exist, that cost shares and co-pays don't exist as a barrier to care.
Well, short term, we've got to stop the hemorrhaging. We've got to stop these constant whittling away of the basic primary services that people need. We've got to quit doing more harm.
And at the same time, there are committees meeting as we speak, looking at how are they going to decide if there's a waiting list, who gets on the waiting list first for the AIDS Drug Assistance Program. Here we are, the richest nation in the world, and in Minnesota and in other states where it's even worse, there are people who need HIV drugs who aren't getting them and aren't going to get them. And it's unforgivable.
You may think Minnesota just doesn't have the money to take care of its citizens the way it did in the past. But why? Jay Kudrowski, a former finance commissioner with the state of Minnesota, says the state is running a structural deficit. It's spending $1 million a day more than it's taking in because of those past tax cuts. However, he doesn't see taxes as a liability. He says it's the reason that Minnesota was able to create so many jobs in the past and create a great business climate.
So I think the state has to undo the tax cuts of the past and get the cost of government to be back where it was. The cost of government in Minnesota was about 16% of personal income. And that's probably where it ought to be. I think Minnesotans would feel comfortable with that. Then it would be a question of how to spend it, but they ought to declare that that ought to be the level of spending in the state, that 16 cents out of every dollar personal income go for state government.
Beyond rescinding tax cuts, nearly all we interviewed were unanimous on two things. Everyone deserves health care, and the government must take a more proactive role in providing it. Different terms were used for it: universal health care, single payer, or Medicare for all.
Well, number one, I honestly think we need a single payer system, or like Canada or Britain.
I'm a fan of universal health care programs. There's too much of a difference between the haves and the have-nots from a healthcare perspective now.
So I think broader health care coverage is something that Minnesota needs. I think it's something that Minnesotans believe in fundamentally.
I think that it's time to go back to 1992, to go back to 1993, and to revive our national debate about making access to universal health care a national priority. Minnesota certainly embraced that policy, in fact led it.
And as part of that discussion, it seems to me that just as important is to say, what if I get sick? You know, the protection that, you know, my government is trying to have for me in case a terrorist attacks, and, you know, in case there's a criminal on the streets. Can I ensure that to the extent possible, I'll be protected if I get sick?
So why is it that we can come up with the billions or trillions to pay for military defense and homeland security when we can't come up with the money that we need to protect ourselves from things that are at least as evil as Osama bin Laden, things like the HIV virus?
Well, I think the ultimate solution is that we need to make sure that everybody has coverage.
Even my country, which is not rich enough, has that, has universal care access. And For me, it's really a vital thing.
I've got 6 boys and 2 girls. And I think out of the one boy is dead with AIDS, and out of the rest of them, there's only 2 that can go to the doctor because the jobs don't cover health care. Now, they're not living with HIV or AIDS, you know. And somebody's talking about going to Canada, you know, where they can get proper health care. I don't think we should have to leave our country to go to another country just to get health care. I don't think that's fair at all.
Healthcare, we have to change our whole attitude towards healthcare. This is a human right to have a healthcare, and especially in a society like this. And I'm willing to pay more taxes for that.
But if you take all this money and you put it in one pile, I've heard that we could actually be funding health care for every single citizen of the United States through the same amount of money, not increasing the amount of money that we're putting forth right now. This is blowing my mind.
Kip Sullivan has been working on behalf of universal health care, or what he calls Medicare for All, for over 20 years.
The single most compelling argument for a Medicare for All style system is that you save tons of money, possibly somewhere in the neighborhood of 10 to 30%, maybe even more. But you don't save it the way the current system saves money, which is by damaging quality of care and invading patient privacy. Medicare uses 2% of its revenues for overhead, turning on the lights, paying its 4,000 staff, and pays out the other 98 cents to doctors and hospitals. The average insurance company, private sector insurance company like Blue Cross, will keep 20 cents for all those functions I just mentioned: underwriting, harassing doctors, paying profits, paying obscene salaries, and they'll only pay out 80 cents in health care to docs. So you're going to cut 10 to 15% out of the U.S. health care bill in a single stroke.
There are several things you should keep in mind. First, every other industrialized nation has some form of health care for all. Second, nations with health care for all spend less per person than we do. Third, polls from those countries indicate their citizens feel more positively about their health care system than U.S. citizens do. And finally, countries with health care for all rate significantly better than America on objective criteria like infant mortality rates. So, do we really have the best health care system in the world? And finally, what can you do about any of it?
If the HIV community and doesn't come together for this, we're going to start to see more deaths. Honest to God, I honestly believe that we are going to start seeing people get sick again and starting to die because they're going to have to choose between food, housing, or their meds. And guess which one's going to go?
One of the really important strategies in tackling this whole problem has to be building alliances with other interest groups in the world of healthcare, because there is no good reason why people with HIV should have better access to services than people with cancer, or people with MS, or people with any other condition. As human beings, healthcare ought to be a guaranteed right. And there ought to be access to quality health care in this country, regardless of what state you live in, regardless of whether you're employed or not employed, regardless of whether you're rich or poor. It ought to be something that we have access to like we have access to air to breathe.
Clearly, there are problems with a healthcare system that may deny benefits to low-income people living with HIV, especially since other states found that the money it costs to administer them was not recouped by the cost sharing itself. Did Minnesota's DHS ever do a cost-benefit analysis? We don't know. But beyond the needs of low-income people living with HIV, there is a greater need for health care for all. Minnesota used to lead the nation in its commitment to providing health care for all. Isn't it time we renewed that commitment? For MAP Public Policy, this is Elizabeth Dickinson.